All right. Up next, we're transitioning from our industry talks into the rest of the program, and it's my absolute pleasure to introduce Dr. Linda Laux from Lurie Children's Hospital, who is also the chair of our medical advisory board and has been an absolute stalwart support to the foundation over the years, as evidenced by this conference where she is speaking today and tomorrow for us. So today she'll be giving an overview of Dravet syndrome. Thank you, Linda.
Hi, everyone. As Veronica said, my name's Linda Laux. I'm a pediatric epileptologist at Lurie Children's in Chicago. And as we're transitioning from the pharma space, I just want to say a big welcome to everybody. I was playing with PowerPoint slides, so was able to come up with this. So it's welcome to Minneapolis. And this is just such a wonderful conference. It really is one of the few places that has the families, the patients, the caregivers, physicians, researchers, the pharmaceutical realm, all in one place. And they're in one place to try to learn and get together, have new ideas, and it's all to try to promote better life for kids with Dravet syndrome. So as always, thank you so much for having me come and talk. I was very happy to be here. So I was asked to give somewhat of an overview of Dravet syndrome, and it always strikes me as interesting because you all know so much about it already. In many cases, have a much more obviously personal connection with it and understand it in some ways that I won't. So I wanted to do something just a little bit different with this talk today as an overview. And it really is to give more of a historical overview of Dravet syndrome, kind of how far we have come, because it is very exciting, as you have heard all morning and afternoon. So we're going to start back when it was first described by Dr. Dravet in 1978 and go on to where we are now in 2024 and beyond. So this is a timeline, obviously not of everything. There's so much other research and important moments that's not included on this, but I wanted just to highlight some of the bigger moments in our journey through Dravet syndrome, starting with Dr. Dravet describing it in 1978 to the International League Against Epilepsy, who then named this Dravet syndrome in 1989. To the discovery of SCN1A mutations in association with epilepsy in 2000, the association of SCN1A mutations with Dravet syndrome specifically in 2001, then the utter importance and amazing job our parent groups have done, both the IDEA League established in 2005 and then the Dravet Syndrome Foundation in 2009, followed by a lot of the exciting progression that you've heard this morning with different pharmaceutical presentations, really first focusing on those that have gotten FDA approval, which started in 2018, and finally going on to some of the gene regulation trials that are ongoing now and certainly will be in the future. And so beyond 2024, what are we expecting? What are our hope? So starting, Dr. Charlotte Dravet recognized the clinical constellation of this epilepsy syndrome. She tells a really, really lovely story. She was a physician at the Centre Saint Paul in Marseille, France, and she actually lived on the premises. And she would watch the kids as they go from their homes to the school of kids that she was evaluating, and that happened to be a group of patients with what we call now Lennox-Gastaut syndrome. And that's a very, very broad term that simply say kids have certain seizure types and EEG pattern, but really it doesn't give you why they're having their seizures. It's a very, very kind of large term. And she noticed as she was watching those kids walk, especially on really bright days when the sunlight was going through the trees, that some of the kids would tend to have some of those myoclonic jerks. And she looked at these kids and realized that they had a lot more in common than she initially realized. They never had an explanation as to why they had their seizures. Seizures would begin early in life. They would have a vast variety of seizures, especially tonic-clonic and myoclonic seizures, which is what she was seeing then. Subsequently, they would have some cognitive and behavior issues. And again, no reason why this was happening. No brain lesions were seen on any imaging testing. So she gathered all of the observational data that she had and published it in a small French journal called Vie Médicale. And the title in 1978 was called Les épilepsies graves de l'enfant. And she subsequently went to a big conference in Kyoto, Japan, the Advances in Epileptology 13th Epilepsy International Symposium in 1982, and really discussed her findings. From that time, people around the world were saying, yes, we see some of these kids. But they also were saying, you know, we have some patients who are kind of like that, but not quite. Maybe their seizures aren't quite as severe as they describe. Maybe there is something atypical to the clinical presentation as to what they described. And there was different variant names that were starting to be given, including severe myoclonic epilepsy borderline, or in Japan they were saying borderland, or SMEB, or the intractable childhood epilepsy with generalized tonic-clonic seizures. So there's kind of more of a broad category. Now, I think what I forgot to mention on the prior slide is that Dr. Dravet had called this syndrome, she termed it severe myoclonic epilepsy in infancy, or SMEI, because the kids that she saw were older and they all had that myoclonic jerks. Those were the kids she was looking at. And when people started to look more worldwide and see that they didn't necessarily have all of these symptoms, people started questioning if there might be a better name. Also, the concern was when you first diagnose these kids and they're infants or very young, they might not have the developmental concerns that some of the older kids would get. So it's confusing to a lot of doctors too, because they would see a child who's 2, might have normal development and say, well, they can't have this syndrome because what she described was very severe. And that's when, in 1989, the International League Against Epilepsy renamed this Dravet syndrome. So you guys will still see in the literature SMEI, SMEB, and the other things, but know that now that's where the name came from. So stopping and looking at what the clinical diagnosis of Dravet syndrome entails, a lot of people have related it to a puzzle, that there's really a lot of puzzle pieces, and it depends on how they kind of interact with each other to actually make this diagnosis, because there's a lot of variability among patients. But typically, the most important parts of the puzzle are the seizure types and the seizure evolution. So we know that when kids are young, they're going to have either those full-body generalized tonic-clonic seizures. Tonic is stiffening, clonic means jerking. Or they'll have some sort of hemiconvulsions, meaning one half of your body is having that clonic, which just means rhythmic jerking. And in fact, one of the most typical signs that we'll see is when you have that clonic jerking on one side of the body one time, and the next seizure might be on the other side of the body. That's called alternating unilateral hemiconvulsions, and it was one of the most specific seizure types that you would see with kids with Dravet syndrome. Subsequently, you might get some myoclonic jerks or those quick muscle jerks. Sometimes they'll be with like some head nods. You can have some atypical absence spells or staring spells. You can have all sorts of other types of focal seizures. The focal seizures with impaired awareness, Dr. Dravet described herself as focal dyscognitive seizures. And that's when the kids would oftentimes be very quiet, look off to the side, not responsive. That could last minutes. But seizures can really come from anywhere in the brain, either generalized or focal areas. We also know that the seizures tend to be very resistant to treatment and very difficult to treat. They oftentimes are very prolonged and can result in status epilepticus. As we already said, the seizure onset is typically in the first year of life. That's been expanded, that age range, a little bit by the International League Against Epilepsy. They often will have very specific seizure triggers. People with epilepsy in general often have seizure triggers, with poor sleep being one of the main ones. But the kids with Dravet syndrome are just much more specific, between the fevers, illness, immunization, hot weather, sudden change of temperature, excitement, sometimes photic stimuli that Dr. Dravet initially had noticed. Now, prior to the seizures, there would be no real medical concerns, unremarkable MRIs and EEGs, with a slight caveat on an EEG obtained immediately after the seizure might have some slowing. And subsequently, the kids will oftentimes have some gait issues, a little imbalance with their gait, developmental impairment, intellectual disability, behavior concerns, and certainly other comorbidities. But again, if you think of all of that as a puzzle piece, somebody might not have all of those different seizure types, but they have some of them. Fit with some of the other things on that list there is that what then gets a diagnosis of Dravet syndrome. I think for physicians that see it often, we can recognize it quite easily. I think perhaps though that sometimes physicians who don't see a lot of patients especially have a difficulty diagnosing this at an early age. But then we get to one of the next big discoveries, and that is the identification that a sodium channel receptor mutation, or SCN1A mutation, is associated with seizures at all. And this was first noted by Andrew Skog, who's at Emory, and he actually talked at one of these conferences, I think maybe last time, 2 years ago. Wonderful person, and he realized that the sodium channel receptor mutation was associated with 2 families who had generalized epilepsy and febrile seizures plus, and it was just a comment in a Nature journal, which he then subsequently had a whole publication on in 2001. And that directly led to a Belgian group saying, well, if it's associated with these generalized, epilepsy and febrile seizures, we should look to see if it might be seen in patients with Dravet syndrome. And they tested 7 kids they knew had Dravet syndrome, and all of them were positive for this SCN1A mutation. Then they tested 189 patients who didn't have Dravet syndrome, and none of them had mutations. So it was very, very, I think, strong evidence at that point. And through the years, we've seen this more and more. Initially, as we went back and this certainly came out, people started with, well, maybe 50% have it. Now, maybe 70% have this mutation. Now we're at the point that 85 to 90% of the patients with Dravet syndrome will have an identifiable sodium channel receptor mutation. This was extremely important to find out. This was the very first epilepsy associated with a single gene mutation. That led to all sorts of research that can be done. That led to it being able to be evaluated electrophysiology-wise, meaning they can look at cells in a petri dish and look at the discharges. They can actually have different animal models that have an SCN1A mutation. You've heard about mouse models, zebrafish, Drosophila models, all sorts. From some of these earlier animal studies by some of the Seattle group, they found all sorts of things, where the seizures were coming from, where that SCN1A mutation was affected in the brain. And then, of course, you can also see what medicines may be helpful. Lots of the different pharmaceutical trials or the gene therapies first look at their medicine in animal models. Then, of course, there was the pluripotential stem cells. What that is, they would take a patient's actual skin cell, program it to be an early embryonic stem cell, and then program it specifically to become a brain cell. And now it has not only the SCN1A mutation, but all of that patient's other DNA in there as well. So there's all sorts of different science, different knowledge that has come out of that identification of Dravet syndrome being highly associated with the sodium channel receptor mutation. Then we go on, and now we're in the 2000s, a little bit farther along, and we have the parent groups. The first one is the IDEA League, or the International Dravet Epilepsy Action League. Who was here at that time? Yeah, there's a few of us. This was actually begun, one of the founders was from here in Minneapolis, and in fact, the first one of these conferences was here in Minneapolis. And again, every 2 years, and they were very, very focused, especially on education and family support. At this point in time, lots of physicians were not diagnosing Dravet syndrome. Many of us would go around the country giving grand rounds on Dravet syndrome just so people would identify it. And now, all neurologists will know what it is and understand at least some of the treatment. There's been so much more research done on it. They also did some grant funding as well. But from this group, there was some people who really, really wanted to focus on that grant funding, really understood that so much more research was needed, and this was an underfunded area. And that was Laurie O'Driscoll, Marianne Meskis, Amanda Rentz, and Janice Stanley. And they broke apart and said, we're going to start the Dravet Syndrome Foundation because we are focusing on research. And to this day, which I had a look on their website, it looks like over $9 million has been granted to research, which is absolutely astounding. But there's But subsequently, the Idea League is no longer. And they then looked out on the group and said, we need to take over also that education and that support. So you can read their mission statement, and what they have done has been just so amazing in all of those areas. Their website is some of the best information that you can get on Dravet syndrome, and obviously continue to excel in all three of those areas. And our next really jump into a major accomplishment or a major notation in the world of Dravet syndrome were these pharmaceutical trials. So these were FDA approval of medications specifically for Dravet syndrome. Never had that before 2018. In 2018, both stiripentol, which is diacomet, as well as Epidiolex were approved, and in 2000, fenfluramine was approved. So that means they are doing very special randomized controlled trials. And you've heard a lot about that this morning, so I don't need to go into it. But what makes a medical trial, one that the FDA is going to approve a drug on, they need to be the patients need to be randomized either to the group receiving the medication or the group receiving placebo, that it should be blinded. Neither the researcher or the families know if the child's actually getting the medicine or the placebo. And there's also set outcome measures, and I think you saw that really nicely with our last talk on the Argus trial. It was like, these are what we are measuring. It's not that they're going to do a trial, gather a bunch of information, and then figure out how to make the numbers look good. They have a set goal, and that is what they look at. So it's absolutely amazing that these three medicines have all gotten approved. And patients with Dravet syndrome have had improved seizure control since that point. And even with improved seizure control, as we have seen for some of the literature out, specifically for fenfluramine, that there's also a suggestion that you have improvements in other areas, which isn't surprising. You quit having so many seizures, of course you're going to be able to develop and learn a little bit more. Of course, there is so much more to come in this area because this is a continuing. And you had a whole morning and afternoon to look at other trials that are ongoing. So very exciting area for Dravet syndrome and continue improvements in seizures and hopefully in quality of life and development and everything else as well. From those studies, we do have a little bit of an idea of how to treat patients with Dravet syndrome. And this tiered approach to treatment or treatment algorithm came from basically getting a whole bunch of experts together around the country and saying, what do you see works? So this is not a randomized controlled trial. This is experts saying what works for them. And you can see on the first tier is valproate. And the second tier, which is actually considered first and second tier, is fenfluramine, stiripentol, or clobazam, and that's Fintepla, diacomet, or Onfi. The third tier is a cannabidiol pharmaceutical grade, or Epidiolex. Then after that, topiramate, or the ketogenic diet, and you can see another box down there as well and what medicines are listed there. In addition, they also express medicines that shouldn't be used or contraindicated, might make seizures worse. There is a notation on there that phenytoin, which is Dilantin, is on that list. However, it might be helpful if somebody comes in with status. Now, I will say already that this is going to be outdated at some point soon because we're going to have new medicines. For patients who have been through these medicines, there's other medicines that we have been looking at that might be helpful. I have individual patients who have had very good responses to perampanel, which is Fycompa, brivaracetam, which is Briviact, and cenobamate, which is Xcopri. So there is very exciting medicines that are currently here, which we maybe just haven't really researched enough in Dravet syndrome, as well as all sorts of new medicines in the pipeline. So very excited in terms of subsequent future treatment possibilities. Now we're going to pivot a little bit to the gene regulation trials, which you had just heard Kim talk about for the Stoke STK001. So as I've already said, about 85 to 90% of patients, Dravet syndrome is caused by a spontaneous heterozygous loss of function mutation in the SCN1A gene, which encodes for the voltage-gated sodium channel type 1 alpha subunit, which is a NaV1.1 receptor. This is on chromosome 2. It's a very, very big gene. And basically, that's my very simplistic diagram to show you that all the patients heterozygous means they have one normal SCN1A gene and one abnormal. Your normal gene will make protein, and your abnormal gene will not. So in these new gene regulation trials, what they are looking to do is basically make the non-mutated protein work harder to overcome the deficit that's caused by the mutated protein, the mutated gene. That's the concept behind those. I do want to note that this is not gene therapy per se. They're not doing anything with the gene that has the mutation. But the hope is, again, they overcome that deficit, then they can treat not only the seizures, but the comorbidities that come with having Dravet syndrome. The gene regulation trials are the Stoke Therapeutics STK001 that started in 2020, and as you heard from Kim, that it has completed its phase 1/2A trial. Phase 1/2A means that's the first time it was given to a human being, and that they're looking primarily at how the drug is tolerated, safety, and pharmacokinetics, meaning dosing. They're figuring out what the dosing is going to be for the next phase 3 trial. The goals for a phase 3 trial is to show the efficacy. You need to prove then that it works, now that you prove that it's safe. The other company that's coming out right now with their phase 1/2A trial is Encoded Therapeutics, or ETX101, which will be starting this year. And I believe on Saturday morning there is a gene trial talks with Dr. Sullivan and Veronica, so I'm sure that they'll give you all the updates for both of those. So again, this has the potential to treat both seizures and comorbidities in Dravet syndrome. So what is our future? Our future are the kids, research, and hope. What we really want to continue is to continue to increase knowledge so we can improve seizure control, improve comorbidities. Ultimate goal, obviously, would be a cure. Until then, we want all the kids to have the best life possible, is our goal at this time. And I just want to say a shout out to all the patients, families, and caregivers out there. As I was looking through different things and researching this, these were all different t-shirts designed on Etsy. And some of them I thought were just brilliant. So certainly, you have so much in your lives and so much happening, but just realize that there is a lot more knowledge that we have, a lot more that we are going to learn, and I think treatment will only just continue to improve with time. So I want to give a big thank you for all the patients and families here, for all the patients and families that I take care of, to the Dravet Syndrome Foundation, really are an amazing organization, and to the people that helped me at Lurie Children's Hospital. We actually have a really nice team here with me this week. Chris, our nurse, Meg, I think back there, Masters is our APN in our Dravet clinic, and Priscilla Duong is our neuropsychologist who'll be speaking tomorrow, I believe. So thank you all very much.